overview about HIV and AIDS นะคะ and epidemic in general, the key populations that we have to discuss about the key population most affected by HIV and AIDS, and some form of intervention, HIV intervention and response. And within this topic that we are going to discuss, I will have the information about Thailand situation as well. Let's start with some of you who may be not familiar with HIV and AIDS. If you see all these abbreviations in the slide, I will share my slide later onนะคะ, to everyone so that you can take more, read more in detail after today's presentation. So these are just some key abbreviation that I'm going to use in my slide, and we are going to talk about this in my presentation today. Let's start with the overview. I'm not sure. In Thai, we have the proverbs saying that we bring the coconut to giving to someone who already planted coconuts. So it's like I bring something that you already know or not, but let's assume that somebody may not have any idea or have very little knowledge about HIV นะคะ So what is HIV? HIV is a virus, no, that attacks immune system and making our body more vulnerable to any infections and other diseases. And HIV is spread through certain bodily fluids within our body. And HIV, since its first discovered, it's become global health issue. We have millions of people living with HIV worldwide, and we have ongoing efforts to preventions and improve access to treatment and care, and that all aim to end the HIV epidemic as the public health threat. And this is what we are going to discuss later in today. The main thing that I want to highlight here is the difference between HIV and AIDS. No, it's quite simple misconception about HIV and AIDS because it's often used like that. You may see people use like HIV/AIDS or HIV and AIDS like this, and it can even though it's often used interchangeably, but it actually two different things. Okay. As I mentioned, HIV is a virus, okay, that attack our immune system, especially the CD4 cells, which are responsible for fighting infections. And HIV, as I mentioned, also HIV transmitted through our blood, semen, vaginal fluids, and breast milk. At the same time, AIDS, acquired immune deficiency syndrome, is a stage of HIV infection. And AIDS is diagnosed when a person has CD4 cell count below 200 cells per millimilli, or develop an AIDS-defining illness. For example, like infection in lung, brain. Okay, so AIDS is a stage of HIV infection. It's not the virus, it's not the same. So you cannot say AIDS virus is not correct, okay? When talking about HIV and AIDS, when you have HIV into in your body, the treatment, some ART treatment or antiretroviral therapy can prevent progression from HIV infection to AIDS.นะคะ. You can see from the photo that I put here, if the above one is that if you get HIV infection and without any treatment, you will develop, the stage of your illness will develop into the fully stage of AIDS. Okay? But if you take, after you get HIV, if you take the treatment, if you take the ART properly and have a good adherence, you will be able to control the virus in your body until you what is called viral load suppression, meaning that viral suppression, meaning that you do not have the virus in your body at the detectable level at all. So when it's not detectable like this, it means that you cannot transmit HIV to other people. Okay, that is what we call U equal U, or undetectable equal untransmittable. We will discuss about this later นะคะ mode of transmission. Please bear with me นะคะ for those who may have very good knowledge about HIV เนาะ This slide having main pathway through which HIV transmission can occur and how they relate to what we call risk behavior เนาะ From the left, sexual acts, HIV transmission can occur. If we're talking about behavior, it means sexual acts and injection drug use. But also the other mode of transmission can be like pregnancy and childbirth and breastfeeding. And also very important to you all as well is occupational exposure that we call. The last one, which is the maybe most risky one, is the blood transfusion or organ transplant. But in many settings today, this risk is very low because we have very good rigorous screening system to prevent HIV blood into system. Okay. Let's put numbers into let's put these into some number that we can discuss นะคะ When talking about the route of transmission, we will have like three type of the possible exposure เนาะ parental blood parental exposure or parental transmission, meaning that it is direct blood to blood transmission. And this is including, of course, like I mentioned, the blood transfusion. And the risk is very high. It's the highest, it's 9,250 risk per 10,000 exposure. So it's almost 100%. But if you look at the number of the other acts, the other exposure acts, you will see is relatively lower. Like even for the blood-to-blood transmission, the needle sharing during injecting drug use is just only 63 risks per 10,000 drug exposure. The below bottom, we will talk about the sexual acts, sexual risk later, but what to highlight here is the receptive anal intercourse, which is taking the most probable risk of infection comparing to other sexual acts. But at the end, when you talk about biting, when you talk about spitting, when you talk about like throwing or throwing body fluid like saliva or semen to other body, or sharing sex toy, it's negligible, meaning that it's very impossible to make you get infection from another person who having HIV and maybe biting you or spitting something to you. But it is important to highlight these things in this table because it is for addressing stigma and misconceptions about HIV transmission. Okay. Let's go into more detail when we talk about sexual transmission risk. Sexual transmission risk is not the same across different type of sexual exposure. That's the main thing that I would like to highlight here. When we say that it's not the same across different type of sexual exposure, is meaning you can see that when we talk about anal sex at the right of my right, I'm not sure if it's your right or your left hand side, and vaginal sex on your right hand side. Okay, when we talk about receptive anal sex, this is the highest, the significantly higher risk of getting HIV transmission or getting HIV infection. If you compare between receptive anal sex and insertive anal sex, the risk of HIV transmission from receptive anal sex is 3 to 23 times higher than from insertive anal sex. Okay. And when you compare between anal sex and vaginal sex, the risk, just let's see between receptive and insertive vaginal sex first. The receptive anal vaginal sex has the risk twice as high as that from insertive vaginal sex, meaning that you have insertive, receptive anal sex or receptive vaginal sex. If you are the one who become the receptor, you will be at higher risk comparing to those who are the insertive sex act. Okay, and if you compare between receptive anal sex and receptive vaginal sex, the risk of transmission from receptive anal sex is up to 18 times higher than from receptive vaginal sex. Okay. Another way of talking about sexual transmission risk is that the sexual transmission risk is not deterministic. Okay, it's probabilistic. What does it mean? It means that a person can acquire HIV from a single exposure, even if the probability is very low. Like, for example, even though insertive vaginal sex, the probability is very low. But if you have other factors, there are some other factors that can increase that risk as well. But if you have like receptive anal sex with the factors that can decrease your risk, comparing to those who have insertive vaginal sex with factors that increase their risk, meaning that you may have less chance even though you have receptive anal sex. Okay, so someone who might have multiple sexual exposure may not become infected. Okay, we can this because of this picture is meaning that we cannot predict outcome at the individual levels based on this average. Okay. When talking about the risk that can be increased, we're talking about if the person you have sex with is having HIV and they have higher viral load, they have STI or you have STI, or some form of vaginal condition that may have tissues damage or inflammation. You may have like tearing or abrasion, or you are during menstruation or bleeding, that all increase the risk of HIV infection. Okay, but the risk at the same time can be decreased significantly as well if the person you have sex with, even though they're having HIV, but they are on ART and they at the stage of viral load suppression, that the volume of the virus in their blood is undetectable, or they are on PrEP or PEP. We are going to talk about this later. The pre-exposure prophylaxis, or the if after sex you use the PEP or post-exposure prophylaxis, that will decrease the risk of your getting HIV or acquire HIV from your sexual partner. And also some using condom, lubricant, and other protective measure as well can help you taking less chance of acquiring HIV. Okay. When talking about the factors, these study review cofactor that modify the risk นะคะ the risk that is not about biological and clinical factors that increase the probability of transmission. For example, like I mentioned, high viral load or some STI can increase the risk, and at the same time, you may have some other factors like using ART, using PrEP, or male circumcision can reduce the risk in some contexts as well. Apart from sexual acts, we also need to talk about another route of transmission that are related more with the behavior of people taking risk of getting HIV. This is what we call injecting drug use among injecting drug user, okay, which is one of the most efficient route of transmission, and it is direct blood to blood contact, okay. So if a negative person use needle or any injection equipment that has already been used by someone living with HIV, there is a high risk of transmission because even small amounts of blood can carry virus. Okay. And importantly, it's not just about the needle. You can see from the picture that there's the things like syringes, cookers, filters, and even water that used for mixing or rinsing as well. These can become contaminated and contribute to HIV transmission risk. Okay. So if we trying to put this into number, we have the estimated risk at about 1 in 160 per exposure when sharing needle with someone who has HIV. Okay. And this is can reduce by the that the risk can be decreased or reduced by using like needle and syringe, new needle and syringe all the time. Do not share needle and syringe to other harm reduction strategy that are critical to help people who inject drug is apart from needle and syringe program. Maybe we talk about opioid substitution therapy. We talk about safe injection education. Next topic, we are going to talk about the epidemic of HIV. Okay. HIV epidemic, when we say, oh, the slide doesn't move. When we talk about the HIV epidemic, we talk about people around the world, over 38 million people around the world that are currently living with HIV. And because of this, why HIV is a major public health issue. And the epidemic is not evenly distributed, meaning that not every part of the world are affected the same epidemic. Okay. Sub-Saharan Africa carries the largest burden. It's accounting for nearly 2/3 of all people living with HIV. Okay. And because of the context, because of the socio-economic condition, because of the factors like health system capacity as well that make Sub-Saharan Africa becoming the most affected, the highest prevalence of HIV comparing to other part of the world. And at the same time, many other regions, the HIV is not generalized in the whole population, but is called concentrated in some specific group. For example, gay men or other men having sex with men, people who inject drug that we talk a lot, we talk about the route of transmission before, sex worker, transgender population. So the epidemic is not just only shaped by geography, but it's also shaped by the population vulnerability. Okay. When we're talking about epidemic, there are three main categories of epidemic. The first one is low-level epidemic. Okay, the HIV prevalence is very low and transmission is limited. Second one we call concentrated epidemic. the HIV prevalence is high in specific key population. We will talk about it later. And the third one is generalized epidemic. This epidemic HIV is established in broader population and transmission occur widely. Let's start with the low epidemic. Okay. In this type of epidemic, HIV prevalence remain very low in general population, normally or typically below 1%, And importantly, it has not consistently exceed 5% in any specific subpopulation. Okay, so what does this mean? It means that HIV transmission is not sustained at population level. The virus is present, but it does not spread widely across the general population. But transmission tends to occur in specific group, even though it's at very low level. Some specific group like people who inject drug, gay men, men having sex with men, and sex worker like that. Okay. So the strategy for intervention within this low epidemic setting or low level epidemic context is that we need to have target intervention to specific group that may be more exposure or more affected by HIV. For example, like harm reduction for drug users, promotion of safe sex practice, and increased access to testing and treatment service for high-risk group. The next one, which is the situation of Thailand and also Indonesia as well, which we call concentrated epidemic. Okay, the concentrated epidemic HIV prevalence is consistently above 5% in at least one key population. Okay, but remain low in general population. We are going to discuss about the key population later, but I can mention to you right now that the key population meaning to like gay men and men who have sex with men, people who inject drug and sex worker, okay? It is the concentrated epidemic, so it's not yet spread widely into broader population. And the critical concept here is what we call bridging, no? Even though the epidemic is concentrated, there are the bridging or the connection between high-risk group and the general population. We will discuss about this in the Madagascar model. No? And this create the real risk that epidemic can expand beyond this group if prevention is not effective. Okay, so concentrated epidemic is very much need the good surveillance and to monitor and respond to the epidemic. Okay, we need to make sure that the prevention and treatment tailored to specific high risk group, and we need to work on reducing stigma discrimination to improve access to service. The maybe last one is the very important one, and this is the context of African country mostly. This is what we call generalized epidemic, okay? In this context, HIV is no longer confined to some specific group, but it's firmly established in general population, okay? It is often defined as HIV prevalence consistently exceeding 1% in pregnant women attending ANC clinic, which is the proxy for broader population, okay? In some countries, for example, in sub-Saharan Africa, prevalence can be extremely high, even exceeding 20% in some countries, okay? So the key difference here is that transmission is sustained within the general population, primarily through sexual networks, but not the thing that is make this different from the concentrated epidemic is that we don't need to be part of the specific high risk group because the overall population risk is elevated. Okay. And the epidemic affect general workforce, affect families, affect communities, and the broader economy as well. The impact is not just health related, but it's also societal and economic. The challenge is the scale of the epidemic. Okay. We can no longer rely on target intervention. We need population-wide response, for example, like widespread HIV testing, universal access to treatment, broad intervention, broad prevention campaign, and addressing structural issues, for example, like gender inequality. This is what I mentioned earlier about how the concentrated epidemic can transition to become generalized HIV epidemic. The paper, you see the reference down here, you can take more look into detail. It's the case of Madagascar. What we see here is what we call a dynamic process. Dynamic process. Now, it's not sudden shift. The epidemic may begin with steady increase in high prevalence among sex workers. You see here is the sex worker is the starting point, and the transmission does not stay contained, but it spill over to general population through what we call bleaching population. So how it's bleached to other population. You're talking about sex worker. We're talking about sex worker male clients. And these sex worker male client may have their own wife, or they may have sex with other people like other girls or adolescent girls or young women. So these adolescent girls and young women will be you'll be at risk of acquiring HIV from male clients of sex worker. Okay. And again, these adolescent girls and young women may have sex with another man, right? May have sex with another man, and this can increase the risk or make the risk of transmission occur. And then these male who are sexual partner of these women who have sex with the male clients of sex worker may have sex with another female, and these female can become the partner, sexual partner of these males clients of sex worker as well. And this is what we call bleaching population. And because of this situation, because of this dynamic that make the how to call the HIV epidemic transition from concentrated to generalized epidemic. Okay, you can take a look more in more detail of this paper that I put the reference here. Another one that is very important as well, but it's not happened to many part of the world very much, but it's affect mostly in the African country, what we call hyperendemic. Okay, the hyperendemic is the level of HIV prevalence very extremely high. So often 15 to 20% or more in general adult population. So it's not confined to a specific group, no, it's not concentrated to a specific group, and it's affect entire society. As you see that in several countries in Southern Africa, the red one, this means that in practice, HIV is deeply embedded in population with major impact, the life expectancy, child mortality, or overall economic development. Hyperendemic does not happen because of a single factor. It results from complex interplay of multiple forces, for example, like biological factors, social norm, economic inequality, political and structural condition, and these factors reinforce each other. creating environments where transmission is sustained and widespread. In sub-Saharan in Africa, you may if you read some article, you may find what they call the culture that affect the transmission of HIV a lot is the female genital cut, like they have the small cut of their genital, and that's increase the risk biologically to HIV, acquiring HIV, and that is one of the main cause that make HIV transmission getting higher and become hyperendemic. Okay, so after we look at the definition of the epidemic, no, I would like to walk you through this report of UNAIDS, the latest report of UNAIDS that talking about global epidemic. Okay, when we talk about the global trends, you see these two graphs, no? On the left-hand side is the new HIV infection. So when we talk about HIV epidemic, we have several statistics or several data that we need to focus on. The first one is new infection, number of new infection, and then number of AIDS-related deaths. You see this, the difference between how they use HIV and AIDS, no? Number of new HIV infection and number of AIDS-related deaths significantly dropped by HIV infection rate. HIV new infection dropped by 40% since 2010, and AIDS-related deaths declined even more by over 50%. And this is because the scale up of antiretrovirus therapy of the prevention programs and improved diagnostic. But these declines are not fast enough to meet the global target. And importantly, the progress is slowing, which raises concern about whether we can sustain this gain. Okay, you may have heard about the Trump administration that cut off budget of HIV program around the world, and that make the trend of these, even though it's still on decreasing trend, but it's getting slower very much or significantly. My slide doesn't move very well. Now, the next thing is the next number that we need to take a look when we're talking about the epidemic is the distribution of people living with HIV or HIV prevalence. Okay, when we look at this graph, nearly 2/3 of the people living with HIV are in African continent. You will see that these are orange and yellow from Western Central Africa and in Middle East, North Africa, and Eastern Southern Africa. Okay, it's account for 2/3 of all people living with HIV around the world. And in other regions like in Asia Pacific, Latin America, and Europe contribute to smaller proportion like this. And this tells us that the global epidemic is geographical concentrated, even though it's global in scope. Okay. Now, the distribution of new HIV infection, the new infection or the infection that occur newly for each year, not cumulative number of infection. Like when we're talking about HIV prevalence, it means that it's the cumulative number of people living with HIV. But the new infection is the new one that happen every year. So half of the all new infection again occur in sub-Saharan Africa, and in other region also sharing the this growing number like in Asia and Eastern Europe. No, that is very much here. Okay. When we talk about HIV prevalence, HIV prevalence or the cumulative number of HIV living with people living with HIV, we need to talk about the key population as well. And this report also having this graph that tell you that HIV prevalence among key population is significantly higher than in general population. Okay, so the general population is in green. Okay, and oh no, the general population is here, is around the world. Now, this is the global number. It's just only 2.7%. Okay, but when you talk about other key population like sex worker, gay men and other men having sex with men, people who inject drug and transgender people, and also people in closed setting or people in prison, you see the proportion are very much higher. Okay. Now we have around 7 to 8% HIV prevalence among men having sex with men, meaning that among the overall estimated number of people who have sex, men having sex with men, 7 to 8% of them are having HIV. Okay. In Thailand, when we talk about Thailand, we see that HIV epidemic is maybe what we call it like it is not equally or evenly geographical in terms of geographical, but we see that among our 77 provinces, 50% of new infection occur in only 15 provinces. This is the report from the Ministry of Public Health in 2024. Okay, so it's concentrated in Bangkok and like in down south, like in Songkhla, Nakhon Si Thammarat, Chiang Mai, Mae Hong Son in the north, and many provinces in the northeastern. Okay, and when we're talking about the proportion or the main root cause of the main root of HIV transmission, we still find that newly infection occur very much by the male to male sex. Okay, and zero discordant couples, you know that zero discordant couple meaning that a couples wife or a partner, sexual partners who one is one is HIV positive and another one is not HIV positive. Okay, and transmission occur among these couples 20%, casual sex 8%, commercial sex or sex worker to sex worker is less than 5%, and also sharing needle and saline about 3%. Okay. And the other snapshot is that in Thailand, we have new infection per year at about 9,100 new infection per year. And we have cumulative number of people living with HIV over almost 600,000 people. But remember that this is the estimate number, okay? This is the number from modeling. We don't know the actual number of people living with HIV, but there is ways, there is the means to calculate and estimate this number. But the number that is real, that we can have the record in our public health system is this number of people on ART or on the antiretroviral therapy, okay, or ACE treatment is almost 500,000, okay, for 474,000 on ART, which is account for about 80% of the number of people living with HIV. And we have about 12,000 AIDS-related deaths per year. Overall, our new infection is still on the trend of increasing trend, but the total number of people living with HIV or HIV prevalence is estimated to be lower, and that is related deaths also at declining prevalence. But if you look at the real prevalence of people who are key population, female sex worker is the lowest at the HIV prevalence, okay, which is about only 1%, okay, 1 or 2%. And the highest one is about among people who inject drug, followed by MSM in general, or gay men, or men who have sex with men in general. But the group of male sex worker and transgender people are also quite similar, which is about 4% among them. Then I would like to talk about these key population when we talk about the high number or the high HIV prevalence among this population. Then I think we need to take a look at into detail why these key population are at higher risk. Okay. When we talk about the key population in HIV, we know that UNAIDS identifies certain population as key populations in the context of HIV. No? Here we have gay men and other men who have sex with men. Okay. Make sure that you use the term like this, because remember that not all men who have sex with other men are gay. Okay, there may be some other men who have sex with another men by their work, like male sex worker, but they are not gay. So we should not exclude them from these key population, and we need to also make sure that we understand the behavior of these gay men who really have sex with maybe men and other trans men or other gender identity as well. And we're talking about transgender individuals. Nowadays, it used to be just only transgender women, but nowadays we have more people, more transgender men in the group as well. So these are the group of population that has higher risk, okay, and become key population in HIV. We talk about people who inject drug. We talk about sex worker, and we talk about people in prison and closed setting. Okay, let's start with the gay men and other men who have sex with men. Of course, we discussed at the beginning that anal intercourse has the highest risk of HIV transmission, and higher when we compare with vaginal intercourse, okay? It's due to the rectal lining, the fragility of rectal lining, and the presence of immune cell that can be infected by HIV. So because of these biological factors, gay men and other men who have sex with men are at high risk or become key population in HIV program, okay? And the other factors that make people, this group of people are more vulnerable to HIV is that most of them have more sexual partners compared to general population. They can have like 10, 6, how to say 10, 20s or more within a year, or within months, or within years, okay? And we have a lot of stigma and discrimination. I'm sure that in Indonesia also facing this situation of stigma and discrimination against gay men and men having sex with men as well. And this stigma discrimination can lead to socio-economic marginalization, and most importantly, it limit access to healthcare and prevention resources for these gay men and men having sex with men. Okay, we also talking about legal policy barriers, because some country criminalize same-sex behavior, like in Middle East or in African countries, and even religious prohibition of having sex among same-sex as well. And these can create some barriers to access to HIV prevention treatment service as well. We may have the issue of limited access to prevention resources for men and gay men. It's also not only for accessibility, but also the availability. Like in some African country, because of the Christianity not allow gay men. So the interventions or HIV prevention to target gay men and men having sex with men will never be allowed as well. So this because this affect to the limited access to prevention of HIV resources. Okay. Next group is transgender individual. Again, the biological factors are the same as the men having sex with men because most of transgender women may having like anal sex mostly, and they may have other factors such as genital trauma and inflammation that make them having sex in the way that increase their risk. Okay. Of course, there are some kind of stigma discrimination. There are the issue of lack of access to healthcare, same thing as the MSM as well, and substance use. Normally, we are not labeling that transgender individuals are more in drug and use, but in case that they have used alcohol and drug, it can increase the risk of HIV transmission even more. I forgot to put this into the other population. Actually, the substance use should be put for other key population as well because MSM, sex worker, and yeah, will have a chance to use substance as well. And risky sexual behavior is also the factors that increase their risk to HIV. Sex worker, of course, we have when we talk about sex worker, we talk about female sex worker, male sex worker, and transgender sex worker. Okay. And the context of sex worker is, of course, when they have sex with multiple partners, when they have sex with clients, they need to make sure that they use condom consistently. But in reality, it's very difficult for them to use condom consistently. So sex worker may face pressure from clients to have sex without condom, and this, of course, increase the risk of HIV transmission. And in many settings, sex workers may have limited access to prevention. They may face social stigma, discrimination, and even the legal discrimination as well. Or they're not under legal protection as to become sex worker. And violence, abuse can increase their vulnerability to HIV. And many sex workers are more likely to migrate, okay, move from one place to another place and become displaced. So in this setting of in the context of migration, sex worker can have limited access to healthcare and prevention resources, and that increase their vulnerability to HIV. Yeah, like I mentioned earlier, that criminalization or the legal that not protect them. The criminalization of sex work can link to increased vulnerability to HIV among sex workers because of the lack of legal protection, and that increased stigma discrimination against sex workers. There are many studies to that show the discrimination, how discrimination criminalization of sex worker can lead to HIV vulnerability, and at the same time, how decriminalization can lead to improved health outcome as well. You can search for paper to read.นะคะ. People who inject drug, another key group of key population, and in Thailand, this group have highest prevalence, HIV prevalence นะคะ and the situation of this group also including that they have sharing needle and injecting equipment that increase the risk of HIV infection. They may have unsafe injection practice such as even though they don't share needle with other, but if they use unsterilized equipment, they use needle and saline, non-medical injectable, that can also increase the risk of HIV transmission, especially if they have other sexual contacts or sexual behavior that are not safe as well. They face stigma and discrimination a lot that can limit their access to HIV and healthcare resources. And there are overlapping risks that I mentioned that PIVT or people who inject drug can engage in other behavior that increase the risk, like unprotected sex or sharing personal hygiene items. Prisoners or people in prison or other closed setting, the context of overcrowding, the context that they have limited access to prevention and treatment resources, and the high risk behaviors. When most of the time when we talk about HIV among people in prison, we more likely to talk about male prisoners. And that male prisoner, when they have sex, they have anal sex, no, receptive and insertive anal sex that, and it has highest risk comparing to other sex context,นะคะ. And stigma and discrimination also may increase their risk, and it can discourage them from seeking testing and treatment. Like, for example, after they become released from the prison, and during the time that they were in the prison, they may have sex, unsafe and unprotected sex, because condom is not available widely in most of the prisons, because people are not expected to have sex in prison. Okay, so it's difficult in many settings to provide condom, to distribute condom to prisoners. Okay, so when they have sex in prison and they have unprotected sex or unsafe sex, when they come out, or when they are released from the prison, they may feel like they want to have HIV testing to make sure that they were safe after a long time of unsafe behavior, but because of stigma and discrimination, these can discourage them from seeking testing and treatment later on, even though after be released from the prison. Okay, and that's why all these population are the key population in HIV prevention and program. We also need to talk about dual vulnerability or overlap marginalized identity that can increase the risk of HIV. For example, like I mentioned earlier, maybe you have sex worker or transgender people who also using drug. Okay, you also talking about people like transgender or gay men who may face stigma discrimination because of that gender identity, that can increase their vulnerable to HIV infection as well. And especially the male sex worker who may feel like they do not want to have to become sex worker, but they are gay men, but they need to work on that occupation, and this can increase their vulnerability to HIV infection. Okay. So dual vulnerability can increase the risk of HIV infection due to the limited access to prevention treatment resources, and also because of they face the higher level of stigma and discrimination. Addressing the need of key population is very important. Okay, it's important because it can help reducing HIV transmission and improving health outcome of this population. So we need to talk about social and structural factors, such as, like what I mentioned earlier, the criminalization of sex worker or gay people, and other form of stigma discrimination. And also we need to talk about improving access to healthcare and social service. Okay. I'm not sure if it's okay to continue to the end or should we have a quick break before we come back and start again. Dr. Novia, and I'll have about 20 slides more. Should I continue to the end, right?
I think you can continue again.
Okay,ค่ะ. So next, I would like to introduce you to some kind of HIV intervention and responses that we are having now. I'm sure that many of them or most of them are also available in Indonesia. When we're talking about HIV response or HIV program now, it's important to talk about the combination of HIV prevention and strategy, okay? We talk about the combination of biomedical, behavioral, and structural program, okay? And we need to ensure that they have accessible and actually used by those at higher risk. Okay. When we talk about biomedical, when we talk about the biomedical component, we need to talk about the tools like HIV testing, ART treatment, ARV treatment, PrEP. We talk about condom harm reduction services, and these are very effective or highly effective at individual level. Okay. But the biomedical tools alone are not enough. We also need to talk about behavioral interventions such as counseling, comprehensive sexuality education, peer-led program to support uptake, adherence, and sustained use. Okay. We also need to talk about the structural that link to what we discussed earlier, that we have to address the issue of criminalization or stigma discrimination as well. So the structural intervention include decriminalization of key population, reducing stigma discrimination, legal protection, gender equity intervention, because without these, people cannot safely access to the service we just discussed, okay? So remember all these three dimensions, okay? When we talk about the behavioral intervention, we need to see what are the highly impact behavioral intervention. These interventions are most effective because they are targeted and practical. For example, the adherence support. The adherence support is the critical for both treatment and PrEP. Oh, really? Okay. No, wait. When we talk about behavioral intervention, we talk about comprehension, sexuality education. We talk about condom promotion, negotiation skill. We talk about the adherence support for ART and PrEP as well, not the ART and the PrEP itself, because we talk about the peer-led education that improve uptakes among key population. And behavioral strategy are especially important at the entry points of the prevention cascade. Okay, and they may affect or they matter most among adolescent, young adults, among key populations, among early prevention cascade. Next, we talk about what they call next generation biomedical prevention. The biomedical prevention advanced significantly, especially with long-acting options like what they call cabotegravir and Lena Kapavia. Sorry, I may not pronounce it fluently. This can reduce it's the long-acting PrEP, okay, pre-exposure prophylaxis, and this can reduce adherence burden dramatically. And the key question is that no longer they work. It's who can actually access them. Okay, meaning that even though these work, okay, oral PrEP effective, but it's adherence dependent, meaning that they may have, there may be some people who cannot take PrEP very consistently, so the prevention effectiveness can be decreased as well. But if you have the issue with the adherence, you may think about long-acting PrEP. So you take these two like every 2 months and every 6 months that can address your issue of adherence. But the thing is that it's not available in most of the setting, in many settings. Okay, you may need to think about rapid ART initiation for those who have HIV testing and diagnosed as HIV positive to make sure that once they were found HIV positive, they need to get into ART very as soon as possible so that when they have viral suppression, they can become like treatment as prevention, meaning that they can suppress their viral load and they cannot transmit HIV to other people anymore. Okay, so these biomedical prevention are very effective. Everything are very effective, but the thing is that whether or not you can access to them. Okay. And I'm not sure if any of you have heard about the 2030 target. The world, like globally, we aim to end AIDS by 2030. And the new era of the HIV prevention is that we need to make a shift that is both strategy and necessary to achieve the goal in 2030. We are facing increased constraint because of the Trump administration and because of the financial, structural, and epidemiological. But also we have a new opportunity as well because we have biomedical interventions and that are more advanced. Okay. The key message here is that transition on the right, that on this table that you see. Traditionally, HIV prevention has been intervention center. Okay, so you have limited choices, often requiring strict daily adherence and largely driven by providers and donor funding. Programs have been fragmented with multiple roadmaps and many long-term aspirational goals. But when we come into the new era of HIV prevention to move toward 2030, the paradigm shift is being from move from intervention center to person center. Okay, this meaning that we need to expand both short and long term prevention options, simplifying access to a more focused framework and setting clear, measurable annual targets. And importantly, we move from fragmented projects to integrated national programs with stronger community and leadership self-care models. And finally, there is the critical shift in governance. We need to talk about we need to change from donor dependence to country ownership and sustainable investment. So overall, this is not just about scaling up intervention, but it's about redesigning system around people, choices, and sustainability. This is the global framework, okay, Prevention 2030 global framework, which is built around people's real life prevention journeys rather than isolated intervention. At its core, the framework recognizes the effective HIV prevention require 4 things. First, people need to understand their risk, the available options, and how prevention works. Second, they must be able to access service consistently and without barriers. Okay. Third, they need to use the prevention option effectively in a way that fit their life. Okay. And fourth, they should experience enabling environment, meaning that it needs to be free from stigma, discrimination, and structural barriers. These four dimensions are reflected in the diagram, and it's what we call people-centered design and communication. It is about ensuring individual to understand HIV risk. It is about the prevention platform or system, how the service should be delivered. It includes integrated HIV on health services, community-led outreach, digital or AI support tools, and access point beyond clinics such as pharmacy or workplaces. And we talk about the biomedical prevention option, what people actually use and need to use them effectively. Okay, and we talk about the enabling um, um, context as well. Yeah, I mentioned several times about PrEP and PEP. I'm not sure if you are all familiar with this PrEP and PEP, but for some of you who may not be familiar with this PrEP and PEP, I would like to spend a few minutes to talk about it. PrEP, okay, and PEP. PrEP is pre-exposure prophylaxis. It is taken before you have potential exposure to HIV. So it is designed for people who are HIV negative. If you are already HIV positive, you cannot take PrEP, okay? It is designed for people who are HIV negative, but at ongoing or at higher risk, such as you may have sexual contact, you have injecting drug use. So when you take PrEP consistently, it is very highly effective to preventing HIV by stopping the virus from establishing infection in the body. At the same time, in contrast, PrEP or post-exposure prophylaxis is used after. Okay, this one is before. PrEP is after the potential exposure. It is like emergency intervention. It must be started as soon as possible, ideally within a few hours or no later than 72 hours after exposure, and then taken continuously for 28 days. So the key distinction is that PrEP is proactive and ongoing, used before risk occur, but PrEP is reactive and time sensitive, used after a specific incident. But both PrEP and PrEP rely on antiretroviral medicine, but they serve different roles within comprehensive prevention strategy. I always compare PrEP and PrEP with the contraceptive pills and the emergency pills. Okay, contraceptive pills you take like every day, to prevent pregnancy, but emergency pill you take after maybe you didn't use condom, maybe you didn't take contraceptive pills properly, and you have sex and you don't want to get pregnant, so you take emergency pill um, as soon as possible and before 72 hours again as well. This is what I like. I always compare to my student, PrEP and PEP. This graph, this slide showing how the daily oral PrEP and the long-acting PEP work. Okay, for the daily oral PrEP, I mean, if you take oral PrEP, it's like oral contraceptive pills. You need to take it every day. Okay, so it needs very high adherence. So the burden is that if you miss the dose, compromising efficacy. Okay, if you miss the dose, it may affect the efficacy of the prevention. But at the same time, in contrast, instead of taking daily dosing, you may take only a single injection that provides sustained drug level over months. Okay, so rather than relying on behavioral adherence of this taking every day, protection is maintained through through the long acting. Okay, and the drugs stay in the body at the protective levels over time. Okay. I'm not sure if the long-acting PrEP is available in Indonesia or not. Again, this is what I mentioned earlier. The undetectable equal untransmittable, okay? What we call U equal U. The U equal U meaning that when a person living with HIV is on effective antiretroviral therapy, they can achieve an undetectable viral load and they cannot pass HIV to their sexual partner. Okay, so undetectable viral load refer to when the amount of HIV in the blood is extremely low, normally below 200 copies per milliliter. So low, it's so low that standard tests cannot detect it. So it's called viral suppression. This diagram show that before treatment, viral load is high and detectable, like in full this tube. But with consistent ART, the virus is suppressed to undetectable level. Okay. U equal U is not just a clinical concept, but it is also a powerful public health and social message. It shows that HIV treatment is also prevention. It helps reducing stigma by reinforcing that people living with HIV who are on treatment can live healthy life and have safe relationships, meaning that people who have HIV can have sex still if they are on ARV and good enough to have viral load suppression like this. So in the broader prevention framework, U equal U highlights the essential roles of treatment as prevention alongside PrEP and PrEP. And another thing that we need to talk about in the new era of HIV prevention is differentiated service delivery. We need to redesign program or redesign services around people's life. Differentiate service delivery, reduce clinic burdens, and improve retention, especially for population that are often excluded from traditional system. Like we talking about client-centered care models, we talking about the treatment that are tailored for key population, youth and mobile population. And the goal is to reduce friction in care cascade. Structural intervention, we talked about that earlier, the main goal is to remove barriers to HIV service. Like we need to decriminalize of key population. We need to work on gender-based violence prevention, legal and policy reform, anti-stigma intervention, okay? So there are evidence that structural change can help higher uptake of services. The I'm sorry about the noise, okay? The very important thing is that the structural barrier undermining clinical care, it is like the tip of iceberg, okay, model that show how structural barriers undermine clinical HIV care. What we often see is above the water. What we often see is above the water that we see relative low testing rates are all the problem that we see. Okay, like people having low HIV testing, we do not have, particularly among key population that do not having HIV testing, we can see drop off from care cascade. This is the data of Thailand public health information, okay, that we have 16% gap between diagnosis and initiation of treatment, meaning that people who have HIV testing and found HIV positive, 16% of them drop off from ART. Okay. And the visible are only the tip of the iceberg, but below the surface is more problem, which is most related to structural drivers. For example, we talk about criminalization. We have a lot of, like in Thailand, we have the situation of criminalization of sex worker, that we still have the law prevention and suppression of prostitution acts that push sex worker underground and making outreach service delivery more harder, much harder. We still have in Thailand, we still have the punitive drug policy. So fear of arrest, compulsory detention can discourage people who inject drug from accessing to harm reduction and HIV services. And the third one is the stigma and lack of legal protection. For example, the absence of discrimination laws for transgender people that can create environments and where individuals avoid care altogether. And finally, the poverty and migration status, which can limit access to services and force individuals into higher risk survival strategy. So the key message here is that clinical intervention alone are not enough. If we do not address these structural determinants, we will continue to see gaps in testing, treatment, prevention outcomes to truly strengthen HIV response. So we need to move beyond the surface and tackle what's happening underneath. Let me move just a little bit, okay, to avoid the noise. Um, wait, I almost done. Okay, so this slide highlight key strategic shift in HIV response that move towards the combination of HIV intervention that I mentioned earlier that we need to work on to like combine biomedical, behavioral, and structural altogether. No single intervention is sufficient on its own. Okay, that's the key message here. So the impact from combining biomedical, behavioral, and structural approaches is very important. Another thing when talking about HIV program, HIV responses, we need to talk about how the situation or how the comorbidity and syndemic integration are working. When talking about HIV nowadays, we know that HIV is multiple multi-morbidity conditions. Okay, we need to look at how TB or tuberculosis affect or associate with HIV risk. Okay, we talk about viral hepatitis B and C. We talk about mental health. We talk about substantive use. And this is what we call syndemic integration. And because of HIV infected people, may having all these other infection and non-infection problems like this, the recommendation is that we need to have one-stop clinics that combine HIV, TB, hepatitis, and psychiatrist support to prevent care dropout. I would like to talk about the global targets, okay? So that you will understand what we talk about and why how the global are working to achieve the target. The global targets, the uh let me see. This global target is initiated by organizations like UNAIDS, WHO, and the Global Fund. Okay, they have this comprehensive response that span to towards prevention, treatment, and care, and the effort is to reduce stigma and discrimination as well. The target, what we need to talk about the target is that you may need to remember this number. Huh? The number is 90, 95, 95, 95 target. 95, the first 95 is we need to make sure that we have 95% of people living with HIV to know their status. Okay, so not all people who have HIV infection in their body know that they already have HIV infection. So the goals of the intervention, the goal of HIV program is to make sure that among those who having HIV in your country, 95% of them knowing their status. And among 95%, and among those who know their status already through HIV testing, no, we need to have 95% or more of those who are who diagnosed as HIV positive to be on ARV. And for those who be on ARV, we need to make sure that 95% or more of them having viral load suppression so that they cannot transmit HIV to other people anymore. And these are the global progress so far. Even though we set the target that we need to have 95, 95, 95, but in general, many countries report to UNAIDS reported that only 87%, only 87% of people living with HIV around the world knowing that status. Okay. And among people who know that status, only 77% of them are on ARV. And among those who on ARV, only 73% around 73% having viral suppression. Okay, so we have a long way to go to achieve the target of 95, 95, 95. And this is the progress across the region. You see that almost no region except this Eastern and Southern Africa that almost achieve the target, no? 95, 95, 95 it is only 93, 91, and 95. Comparing to Thailand here, Thailand is not, we may be very good, I mean that very effective in the way that we have people living with HIV to access to HIV blood tests and knowing their status, okay? But we still have problem in having people among those people who have HIV infected to access to ARV, to initiate ARV right away. So it's just only 92%. But we do good in terms of having people who are on ARV already to maintain or to have a good adherence of ARV and can finally achieve the viral suppression. So we have almost 100% of them who are on ARV having HIV viral suppression. Okay. In the report of UNAIDS, this is the quote that I think is important to note it here as well. that the effect of the cut in the budget make the life of people about a third of the estimate annual budget cut, and meaning that every person who receives HIV prevention service, there are three of them left unprotected. Okay, for every person who receive HIV services, there are still three others were left unprotected. So the aim to achieve the target, we need to prioritize. Okay, we need to have like top line of the global target. This slide summarizes the 16 global targets set by UNAIDS to end AIDS as public health threat by 2030. And rather than focusing on single intervention, this target reflect a whole system approach, combining treatment, prevention, rights, community, and financing. And we have, of course, the treatment cascade. We still have to move toward this treatment cascade to have 95, 95, 95, okay, 95, knowing that status 95% of those diagnosed are on treatment and 95% of those on treatment are virally suppressed. So this remains the foundation of epidemic control. We need to have prevention scale up. So the goal is we need to have 90% of people at risk should have access to effective prevention options, including PrEP, condom, harm reduction, and others. This is where we currently falling short globally, okay? The third one is that we need to address the structural factors like reducing stigma discrimination to below 10%, address gender inequality and violence, remove punitive law that block access to service. And these are clinical because epidemics are socially driven, not just biomedical. The fourth one is we need to work on community-led response. Okay, we need to encourage community leadership. Community organizations should be able to deliver 30% of test and treatment support, 80% of prevention service, and 60% of enabling intervention. The fifth one is the integration of sustainable system. We talking about the integrating HIV with primary health care and sexual reproductive health, ensure sustained financing, including domestic investment, improving access to affordable diagnostic and treatment, because HIV is now long-term chronic response, not an emergency-only model. Okay. And at the end, the outcomes target, all of these targets coverage should to go to in order to achieve three outcomes. The first outcome is 90% reduction in new infections and 90% reduction in AIDS-related death. And the third one is sustainable response beyond to 2030. For Thailand, the prioritization matrix of Thailand roadmap to 2030, okay, this helping us to identify which intervention deliver the greatest impact given cost and feasibility constraint. At the top, we see the scaling up of PrEP combined with condom promotion for MSM and transgender women. Next, we have the universal test and treat using differentiated service delivery. And the third one, we have the structural reforms, specifically the decriminalization of sex work and drug use. We have harm reduction interventions such as needle and saline programs, opioid substitution therapy, because it is essential for people who inject drugs, okay? And the key message here is that intervention is valuable on its own, and the combined package deliver the high impact, okay? This slide, this is one last slide, is the focus on priority structural interventions for Thailand, okay? Emphasizing that legal reform and service integration are essential to accelerate HIV outcome. Starting from the panel one, decriminalization, the current legal framework continue to push key population underground by enacting labor protection for sex works and remove punitive element of prostitution laws, we can significantly improve access to prevention and care. Similarly, decriminalizing personal drug use reduce fears of arrest and enable people who use drugs to engage with harm reductions and HIV services. And panel two, anti-stigma and gender law. We need to work on legal recognition of gender identity, which is critical for improved healthcare access among transgender population. And at the same time, reducing healthcare-related stigma, currently around 16%, is essential to promote earlier testing, better linkage to care and long-term retention. And finally, the panel three, we need to have one-stop syndemic clinics. As I mentioned earlier, this is not about it is about integrated service to reflect real-world health needs, like standardized TB screening for people living with HIV, co-locating mental health services with ART delivery can directly improve adherence and especially among vulnerable groups as well. So the key message here is that there are high impact system reform, but without addressing legal barriers, stigma and fragmented service, biomedical advance alone will not be sufficient. Okay. So I think this is all that I have. And our institute นะคะ have the link in Facebook, Instagram, and Twitter. You can follow us and you can get in touch with me and any of us at the institute. And if you are interested to continue your study for master and a PhD program, we also have the international program provided. And like for the master program, there are scholarships available as well. So I hope to see any of you at the institute as our or my student in the future ค่ะ Thank you very much ค่ะ
Thank you very much for the great presentation. Now we move the discussion session. If you have any question, guys, feel free to raise your hand or write them in the chat box. Okay, any question for the other? Hmm.
They may be tired listening to a very long
No.
presentation.
I think still thinking what student about what he should do question. Okay.
Maybe
And
not a question, but you can give like comments or share your perspectives as well. Anything that you may already know about HIV in your country, don't need to like think about Thailand because I'm sure you have limited information about Thailand situation, right?
okay, I think from my perspective or my opinion, first, Aljan, I'm curious about the digital platform right now, like dating apps, uh, because in Indonesia we also some chatting or social media apps are sometimes misused for activities like prostitution.
Mm.
Uh, how do you think about digital behavior influence HIV transmission, or if if we relate this to the your slide new era of HIV prevention that you mentioned, how can this digital platform be better utilized as part of modern prevention strategies right now? What do you think about that situation, Ajan?
I think the first thing we have to know that the key population they move also from the ground to online more, and it's happened even before COVID-19 epidemic that we faced 2-3 years ago. Okay, the thing is that, like for example, female sex among sex worker, they have they have um they have been working more online. They use Twitters a lot,
Mm.
and they have their own hashtag. You need to
Oh.
know the hashtag, okay?
Mm,
If you want to search for sex worker for yourself or to by someone or something like that, or if you want to have like casual partner, you just need to understand the hashtag. Like for example, in Thai they have hashtag like รับงาน or kind of like entertain or something like that, and you can access to them. So for the HIV program, HIV intervention or prevention program also need to be aware of these shift from on the ground to online, and
mm,
find a way how to access, not just only to access to these key population online, existing online, but also how to provide them with HIV prevention. For example, nowadays we have HIV self-test, right? Uh,
mm,
some organization in Thailand, they provide self-test through online social media as well. So if you have like, if you are a key population and if you taking some risk and you're not sure, you want to have HIV testing and you don't want to show up to the clinic, maybe you can contact these organization. So your question asking how we can use the application to be like effectively access to these people. The first thing is you need to know how to access them, how where they are, and how to like
mm,
your algorithm can find them or something
mm,
like that. And then you need to find a strategy how to provide this intervention into their hands or something like that. That's what
mm.
I'm thinking. Ka.
That is very interesting, yes, to see how digital platform can
Uh,
be a challenge or opportunity in HIV prevention in the future.
mm,
Thank you for the answer. In the chat box, we have uh, Miss Novia Handayani. About the question, I actually have one question, Ajan. As far as I heard, the PrEP implementation in Thailand is good enough. But was there any rejection from the society? But in Indonesia, PrEP was initially given to sex men only, and due to the social cultural situation in Indonesia, the rejection of PrEP is high because
mm,
it can because it can lead to a more risky sexual behavior
mm,
among MSM.
mm. Yeah, I agree with you. At the very beginning, that Thailand started to have PrEP is also provided through project or through program, the same as in Indonesia. You may be at the beginning of providing PrEP, but nowadays PrEP is provided or available for all Thai citizenship. So if you are Thai, you can. It's under healthcare coverage. Okay, Social Security Fund and the health security healthcare coverage by the government, meaning that you don't need to pay for PrEP. You get PrEP for free for everyone. And when it shift from project based into the national scheme like this, it means PrEP is for everyone, not only for MSM. When it used to be for by project, the project has target population, like MSM target, female sex worker target, and all these. But nowadays it changed. That's why it's become better and better. So anyone can take PrEP, okay? The issue about rejection or the stigmatization over people who using PrEP is also used to happen to Thailand as well, but nowadays is become more I mean that less rejection or people are understand more. We need to provide more and more and continuous education to society and people that PrEP is for your prevention. And it doesn't mean that because you are MSM, but it's just, I mean, everyone or anyone can have risk behavior, right? No matter you are MSM or not. So stigmatization of MSM taking higher risk should be eliminated first.ค่ะ. Over to you ค่ะ
Okay, Mrs. Novia, is there any feedback or enough? Okay, thank you, Ajan. Okay, for the others or want to ask question or give opinion or share or consultation about their thesis, maybe for okay, student, any question or opinion or sharing about the HIV uh, experience or sharing or phenomena social culture for in the region. You guys,
I have my email in my slide, the
oh,
first page of my slide, and I can share my slide to into chat box so that they can take a look in more detail. And please feel free to email me after, even after this class, to how to say, to discuss further, or if you have any questions later on, it's okay นะคะ
it's okay. You can share your
but
PPT, yes, in the chat box or
in the chat box, right?
yes, you can share. It's be helpful to study
Yeah.
in their home individually.
Okay, I already shared to everyone.
Thank you for that. Okay, guys, any question for the student?
Maybe they can speak in their language if they don't like comfortable speaking in English, and you can help translate to me. You can
Okay.
talk to them in your language as well, and you can help translate to me later on.
Oke, oke guys, teman-teman, kalau misalnya ada yang tanya silahkan pakai bahasa Indonesia, nanti saya translatekan. Okay, again, I think I have a question one more for me.
Yes.
I think looking ahead, yes, in the future, what do you think innovative approach do you think are needed to achieve HIV elimination in the future? What do you think about the future innovative approach? What do you think? The best practice.
The best practice, the best
Yeah.
practice is, of course, in the integrated model that I mentioned. We cannot do just only one thing, but we need to do everything all the same at the same time, like biomedical intervention, behavioral intervention, and structural intervention. And each country, each context has different in terms of context, no legal religious context and also social context as well that
Mm.
increase vulnerability to some specific group. So the first important thing is to address the structural factors that affect people, and maybe you can increase more accessibility and availability of the biomedical interventions that is important, and make sure that the behavioral interventions are effective enough to ensure people to use the service. But I like the thing that UNS highlight at the end that I put with the four framework of the framework of the HIV intervention 2030 that based on people's how to call journeys of prevention, that we need people to understand their prevention needs and options and benefits. Okay, we need to make sure that people have access to prevention service. We need to make sure that people use prevention option effectively, and we need to make sure that we have enabling environment that people can experience and help them in a good prevention way of preventing HIV ค่ะ
Okay, it is interesting about the answer. I think it should implement it to Indonesia, huh? Yeah, to
อืม
eliminate, to decrease
อืม
case HIV right
อืม
now, especially to
อืม
country like Indonesia.
อืมอืม
Okay, guys, any question? If no question or opinion, maybe okay. One question again from Rayung Kusumajati.
ยุ่ง
Yes, I want to ask about accessibility condom in Thailand. In I think
you
in
translate
Thailand, yes, is in Thailand condoms are readily available, and
uh,
the government even supports them extensively. Uh,
อืม
does the public then utilize these facilities in Thailand? Uh, mm, I think wait a minute. In Thailand, condoms are easily accessible, and the government strongly support access to them. From the community perspective, do people actually make use of these facilities? Like the, in Indonesia, we have primary health, uh, have a condom freely to the risk population. In
อืม
Thailand, same in Indonesia or different?
Actually, in Thailand, access to condom is very how to call it's very easy. Is you can buy from any convenience store. You can buy from 7-Eleven, you can buy from drugstore, you can get from the government. Like if you go to primary healthcare setting, primary healthcare services, they provide free condom for you as well. So condom is available almost, I would say, everywhere for everyone, not to any target population ค่ะ
Do people have to pay for condom in Thailand? Or,
If you buy from convenience store, you pay, but you can
mm,
get it free as well. Like for example, if you go to NGOs that working on HIV, you can get it free. They provide you condom free
mm,
for free. You can go to get it free from hospital, public hospital. You can get it free from primary care unit as well, something like that. So it's your choice. Some people may feel like free condoms is not in a good quality, but actually it's no, it's misconception, it's the same. Okay, so some people may prefer to buy from convenience store so that they can choose the quality, the size, or whatever better.
Is there a schedule for distributing the condom at risk population or what? Or the
No, to
population?
anyone, to
Mm.
anyone, to
Mm.
anyone. Like, have you heard about our Songkran festival, our Songkran New Year, the water
Mm.
festival last week, no? At the same time that people like going to the street and throwing water for water festival, Songkran festival, there are these organizations working on HIV. They're coming out and providing condom for free, distribute condom for free to everyone.
It's interesting.
You can
The-
translate back นะคะ You can spend time translate back to in your language so that
Oh ya,
they will
oke.
know.
Rayung, jadi memang di Thailand itu memang kalau kondom itu bisa ada di diberikan gratis dan ada yang juga berbayar. Jadi memang semua ini gampang lah diakses kalau di Thailand. Nggak jauh beda sih sebenarnya kalau sama dengan Indonesia. Oke, any question again from the student? Oh, one question. Oh, two question. Oke, or Pramita first. Silakan Pramita.
Okay, thank you, Ajahn, for the interesting material and presentation. I want to ask about the data estimate the risk for transgender individuals and gay men based on biological factors. However, in many Indonesian provinces, these populations are hidden due
Mm,
to social and legal pressures.
mm,
How can we rely on the prevalence data you mentioned that the 1% and 5% thresholds if
mm,
the actual size of these key populations is likely unreported
mm,
due to the
mm,
stigma? Could
mm,
the epidemic could be
mm,
more generalized than our current data suggest?
mm.
That's all my question. Thank you.
Very good question. Thank you for asking this question, ค่ะ Actually, there are methodology to collect data. We cannot collect like blood samples from everyone, no, and we cannot like ask everyone whether or not they are part of the key population or not, or something like that. But there's the methodology that used by our epidemiology department and the public health Ministry of Public Health that collect data. I think is also implemented in Indonesia as well, the IBBS methodology that we use the survey and we use maybe RDS, respondent-driven sampling method, to access to this key population, the hidden population, okay, and get them into the survey. And in the survey, we ask the question on the risk behavior, and also we have the blood testing to see the how to say the HIV prevalence among this population, and we also get the number. And of course, as you said, that the number may be just part of the survey, so it's just the get from the available sample size that we have, but it is the only methodology that I think is implemented in any part of the world as well, because we cannot get every people into blood test. But we have another number, like number of people coming to HIV testing services, right? And we get the proportion of these people access to HIV testing into the number. Okay, and we trying at the same time in Thailand and in many countries. I'm guess in Indonesia also they are doing the same thing. They're trying to do what we call size estimation of key population. Okay, there are methodologies that we can use to estimate the total number, the closest number of population, this population. And among this number, we use this number to identify, like to estimate the HIV prevalence among this population as well. And as you said, is they are hidden population. It's very difficult. We may need to use the kind of how to call methodology in order to estimate the risk and the HIV prevalence ค่ะ I'm not sure if I'm clearly answer your question. Is that okay?
Is any feedback, Mita? I think she is understand in English, Mita.
That's enough. Okay, thank you.
Okay, the next, I think in the chat box first. I'm sorry, Selfisina. You have to. Hello Ajan, this from us Masha. In English, I would like to ask about the HIV/AIDS education curriculum in Thailand. How far has it been integrated into the national curriculum? And is the content focused only like medical prevention, or does it include topic like discrimination, consent on the others? All Also, is there any evaluation for the implementation?
The
What do you think?
implementation of the curriculum.
Curriculum.
Actually, we have the sex education program in school level, okay, and HIV is part of that. But unfortunately, I guess I'm not sure. I do not have information like precise information about this, but I guess that the evaluation found that sex education in school level depend very much on the one who deliver it, or depend very much on teacher. So it's not like you deliver the teaching according to the curriculum itself. So no matter how good the curriculum has been made, like talking about gender equality, talking about HIV, talking about sex education and whatever. But if the teacher feel like their student should not have sex, they will deliver the content from the curriculum that according to their own attitudes and their own perspectives, you know. So these are the findings from the evaluation. So I can say that I answered the question is that HIV is integrated in our sex education program. Okay, and we have sex education program for school students from grade 6, 7, or even below grade 6, okay, at a very young age when they were at a kid. But the delivery of the curriculum is very varied across the country.
Are teachers specially trained to deliver HIV/AIDS education, especially on like sensitive topic like consent or stigma? The teacher trained to deliver as
There are
any like
many organizations, like especially Ministry of Public Health, they're trying to work on like training, like deliver the training or workshop for school teacher to help them to deliver effective training on stigma and discrimination as well. There's a lot of training available by many organizations, including Ministry of Public Health and other NGOs ค่ะ
Okay, thank you for the answer, Ajan. Okay, the next question from Shifra. I would like to ask about the key population at risk of HIV, specifically, what health promotion strategies are effective for people living with HIV in prison settings, and what challenges do they commonly face?
Oh, our questions are very good now. Actually, we started in Thailand, we started to have HIV program for prisoners or people in prison setting when we received funding from Global Fund about 10 years ago. And during the time at the beginning, we are not allowed to do anything apart from education, like providing information, HIV information for HIV for prisoners, but not condom yet at that time. Okay, but we try to advocate to the Ministry of Corrections, Ministry of Justice, no, to understand that it is important to provide condom to prisoners in prisons because they have sex anyway. Okay. And if you cannot prevent HIV transmission within prisons, when they come out, when they are released, that will be like kind of like what they call bridging population, like it can spread HIV to other population, and we cannot control the HIV epidemic in our country. So it now become that in prison in Thailand, condom are available, okay, especially in male prisons, and HIV information are available for prisoners as well.
What do you think the biggest barrier in implementing the strategies effectively?
Policy,
Policy.
policy. We have to work a lot to advocate, to do policy advocacy to make people at the policy level understand the need of providing HIV prevention. And now the thing that we cannot do at all is to, because in prison, it's not only sex that they have, but they still use drug. We don't know from where they can get drug, right? And they do injecting drug, and they do also tattooing in the prison, and they use it as like share needle because they have limit number of needles and saline, right? So they share needle, they share the tattoo how to call tools to do, and this increase the risk of HIV. So the main thing, the main problem in prison now, we have condom, right? But we cannot provide safe needle and saline equipment because we cannot promote these in prison. We cannot promote harm reduction. We cannot promote opioid therapy in prison. So the intervention that target unsafe drug use is still the main gaps in prisons.
I think it's the same case in Indonesia, where many people in prison consume drugs. No one knows where they come from. But I think it's challenging from the next issue. Okay, thank you for the answer, Ajan. The next question from Inaka Ainun, I will translate. One of the barriers in addressing HIV among MSM or men who have sex with men is discrimination, right? But which may also affect policy development. Does Thailand currently have a legal or policy framework that uh, explicitly recognize men who sex with men? I understand that Thai media often portray same-sex relationships. Please correct me if I'm mistaken.
Very good, very good. And I'm one of the fan of the Thai series for boys' love as well. So you see that Thailand is quite open, totally open about gay men and gay community นะคะ You can I think you can tell from watching all the media from our country and regarding the law and policy you may have heard about Thailand same-sex marital law that we just have late last year or beginning of this year that allow people at same sex to register their marriage to be legally married as couple. By saying this, meaning that we do not have law decriminalized to criminalize same sexual acts, not like in Indonesia ค่ะ
Uh, I think it's a little bit different, yeah. The
อืม
culture about the the culture about
อืมอืมอืม
prevention and treatment service
อื
for
ม
MSM
อื
in
ม
Indonesia and Thailand
อืมอืม
because we have the social culture in religion
อืม
like MSM is not appropriate
อืม
to post in social media like
อื
that.
มอืมอืมอืม
It's very prohibit
อืม
to.
understand
Okay, thank you for the answer, Ajan. The next question in chat box, or the last question in the chat box. Based on your experience and research, how significant is the government role in influencing the success of HIV case management? Please give suggestion for us who are facing low government support and the pretext of religion.
oh Wow, very important question again. I think the government play very critical roles in controlling HIV situation in Thailand, and especially this day when we gonna have the paradigm shift from donor dependent to the national program. Nowadays, we have, like I mentioned, for PrEP, for HIV testing, PrEP are available under the National Healthcare Scheme. Okay, so for all Thai people can receive all these for free. And also ART, that for people who living with HIV, they can access to ART services for free as well. So I think the main thing in if I can have suggestion for your country, you may need to advocate for do policy advocacy within your country by showing the evidence, maybe from research from other countries, that by doing this intervention, how can it save life of your people, right? If you are like, if you cannot provide condom, if you cannot provide HIV testing to everyone, if you cannot provide ART treatment for everyone, what will happen after that? So working by using evidence would be the best, because the government, they need to I think they need some evidence, some data to help them inform the policy later on. So I think the information and the data is very crucial for advocacy ค่ะ
Thank you for your explanation, or any feedback for Mrs. Ratih or not? Okay, I think it's clear, that government support plays a crucial role in its absence. I think community-based approach is very important also
อืม
in
อืม
sustaining
อืม
HIV case management.
อืม
Okay, thank you for the answer, Ajan. The next question for the student. You can raise hand. Okay, Selvicina, you can unmute.
Okay, thank you, Pak Fahmi. Thank you, Ajan, for your explanation. Hello, my name is Elvisina. I would like to ask a follow-up question regarding your explanation about the distribution of the condoms in Thailand. If the condoms are distributed freely to the community, could that be potentially leading to an increase in sexual activity? Thank you.
I think what we don't need to be afraid of is that people having sex more, but we need to be afraid of people have unsafe sex more. So distributing condom is to encourage people to have safe sex, right? Protect themselves from unsafe situation, whatever, and maybe unplanned pregnancy as well. That would be better. But if you afraid of, I mean, if your government or public health ministry of public health saying that do not provide condom because if you provide condom they will have more sex, but in reality they will, if they have sex they will have sex anyway, and if they do not have condom meaning that they will have sex without condom and it can be unsafe for them ค่ะ
Any follow-up question?
Okay, thank you, Ajern. I would like to ask another question. If that's the case, was there any debate about it, about the distribution of the condoms, or did the community generally agree with it?
A lot ค่ะ especially when we talk about this with teacher in school. You know, Thailand used to trying to have the program to provide condom in school as well, because we know that young people, adolescent, we have research, many research that reveal that age at first sex is getting lower and lower, like 10, 11, 12 years old. So it's important, based on this data, it's important to make sure that young boys and girls can access to condom enough, effectively enough to prevent themselves from unplanned pregnancy and also from STI and HIV. So we try to push to have condom in school, but it got rejected by many teachers in school as the like you just said that these teacher they think that if we provide condom to children, children will have sex. But if you don't provide condom to children, children will not have sex or something like that. But we debate a lot, many years, and nowadays it's getting better and better. I mean, people more accepting that we are not providing condom just in order to let them have sex, but we provide condom in order to let them have safe sex. So if don't providing condom, they still have sex anyway ค่ะ
Okay, Ajern, thank you for your answer.
Thank you ค่ะ welcome ค่ะ
You, Ajan. Okay, the next question or opinion or sharing experience. Okay. Okay, I think before we conclude, may I kindly ask for your closing statement or final remark for us or the student, Ajan?
Me?
Yes.
Okay, my final remark may be advertising for our master program because you all are undergrad program, right? We have the program, the master degree international program on population, sexual and reproductive health, that I am part of that program as well. And we have many Indonesian students from Indonesia almost every year to us. And in this course, this program is 1 year program, okay, for master degree. And in this program, you're gonna learn gender, you're gonna learn about HIV and sexual reproductive health, of course. and you're gonna learn about population, and your thesis can be related to HIV, to sexual and reproductive health and everything. So if you are interested, please feel free to check on our website and or also email me as well. Maybe at the time of when we open for application, I can like share with you all again later. So yeah, hope to see any of you there at IPSR.
Is there a doctoral program too?
Yes, sure. We have a doctoral program on population and social research.
It's it's special for me for
Oh,
doctoral.
good.
I think it's very. I will contact you for the next project or the next planning.
Sure.
Aja.
Welcome.
Okay, thank you so much, Ajam, for your time and sharing for such insightful and valuable perspective with us today. We truly appreciate the knowledge, the experience you have shared, especially in helping us understand the current issues and new direction in HIV prevention. It's a very meaningful session for all of us. On behalf of Undip Global Classroom, we would like to sincerely thank you once again for your contribution today. We wish you continued health, success, and all the best in your future work and research. We hope to have an opportunity to learn from you again in the future. Thank you very much, Ajahn.
Thank you very much.
See you next time.
See you
Thank you.
next time. สวัสดีค่ะ
สวัสดีครับ
Thank you very much, Ajahn.